So I'm a radiation oncologist. I'm talking about radiation oncology for kidney cancer. So I'm going to talk first about radiation folklore, about why maybe radiation is not used as much for kidney cancer as other diseases and why that's changing. Radiation for the primary kidney. Then, as Dr. Sheth mentioned, we'll talk about oligometastatic disease. Then another entity called Oligoprogression, where we may have controlled disease, but otherwise a growing spot. And then finally, palliation. So talking about radiation folklore, when you think about most cancers, there's usually like three pillars, three specialties that are kind of forming the basis of the people that you see and the people you interact with. So that's prostate or colon or whatever cancers. And that's radiation, surgery, and medical oncology. Now, kidney cancer has always been a two-pillar system where you really don't have radiation oncology. And I'll tell you why. Now, originally, the reason why we think radiation is not effective for kidney cancer is become a series of petri dish radiation experiments done back in the 1980s. And they took like 5 patients with prostate and 20 with gastric and just one from kidney, from a 22-year-old with a papillary renal cell. And that's an interesting phenotype. And they radiated them with a small dose of radiation, 2 gray. Then they organized them by how many cells were left over after the radiation. And what they found was this 22-year-old kidney cancer cell line happened to be the most radiation resistant among all cell lines. But it's that is the basis for the radiation resistance in kidney cancer. Now, why did we lose interest in kidney cancer as a field of radiation? And this is a series of studies done in the 1970s and 80s. And this is one of the hallmark studies done, I believe, in Northern Europe. And they took 65 patients with advanced renal cell carcinoma, had nephrectomies, and afterwards randomized them to radiation plus observation versus observation alone. And what this study showed was that among the deaths, a lot of them were due to radiation-induced side effects. An unacceptable amount were due to radiation side effects based on this graph here. So this is a Kaplan-Meier curve. When it drops, that means a patient dies. And this drops more than just observation. So radiation was harming these patients in the 1980s when they were being treated. This is a radiation field published with this paper. And what they did back then was what we call 2D radiation, which is you took a plain film, you did one beam and another beam, and you radiated about 2/3 of the patient's abdomen. And this is an extremely large amount of radiation that covered a lot of area. And it's no wonder that patients had a lot of side effects, including death afterwards. But radiation had changed since then. And over the decades, we have really implemented with technology, with computers, a lot of advances. In the 1980s and earlier, we did 2D radiation. In the 1980s, 1990s, we're now 3D. We're doing imaging. We're using that to plan with actual imaging, how to orientate our beams. This has advanced in the 1990s and 2000s. We're using automated planning to do basically use computers to aid us in figuring out where the radiation is. And now with onboard imaging, where we take imaging that is just as good as diagnostic quality, seconds before we do the radiation, we're now doing SBRT. We're doing high doses of radiation therapy to control the disease with very, very small margins. So the radiation nowadays is light years ahead of what was done back when we were doing the clinical trials. And this is probably the last time you see a randomized clinical trial with radiation therapy that was completed, and that those early ones in which patients passed away, unfortunately. So moving ahead to primary kidney cancer. And I always like to illustrate with the patient that I had. This is not his face. This is just a Google stock image. So a 79-year-old presents with a kidney mass. He then has a nephrectomy in 2016 where they had an unfortunate positive margin, which means tumor is right at where the surgeon cut. So there's cells on the other side. Now, unfortunately, the CT scan afterwards showed a recurrence. He started cabo with significant side effects. And then we decided to stop the cabo and do the radiation with a standard regime of 3 radiation treatments. Because the cabo stopped, the tumor did grow a little bit afterwards, right in the immediate imaging afterwards. But then over the next few years, it remained stable. And this is our radiation plan, which shows a very conformal radiation field around the primary tumor. And then also on the left is the tumor nowadays, pretty much stable, hasn't done anything in 5 years. And that's, for us, a success. So why do we consider this as an option now? And this is really a trial that was done and reported just a few months ago in Australia from Shankar Siva's group, a well-known radiation oncologist in Melbourne. And what they did is they took 70 patients with biopsy-proven kidney cancer, and they did radiation to all, either one treatment for a small tumor or 3 treatments for a larger tumor, and then followed them for about 4 to 5 years. And what they showed was that after that time, there were no local failures. There were 3 patients where a metastasis did develop eventually. Many of them were years later, and no kidney cancer-related deaths. So it's an attractive option. Now, importantly, it's also worth noting the side effect profile, and that had a severe toxicity rate of about 10%, and you did drop your kidney function, and these were mostly larger tumors, by about 14 points on a patient with an average score of 60 points. But these are patients also with other kidney morbidities as well, other problems that could also cause their kidney function to drop. So how does radiation now stack compared to other modalities such as surgery and ablation? There is advantages. We avoid general anesthesia. Some difficult tumor locations we generally can treat. We can treat large tumors. We've treated 10, 15 centimeter tumors. It's a non-invasive technique, so there will be only marks drawn on your skin. However, we will not get pathology on the tumor, so we won't know what it is unless somebody goes in and biopsies it before we do the radiation. Moving on to oligometastatic. Here's a patient of mine, 50-year-old man with a confusion, a brain mass and a kidney mass diagnosed at an ER visit. And this was back in 2008, and the CT scan showed a right kidney mass and a CT brain showed a brain mass. And that was treated very soon afterwards with a nephrectomy and surgery. And at that time, because there was only 2 lesions, there was a discussion about, well, what should we do afterwards? Should we do drug therapy? Should we watch? And they decided to watch. And then a couple months later, they had a spine met that they were resected with radiation. No other lesions. Watched further. 6 years later, we had a pancreatic met treated with resection. 2 years later, 3 brain mets treated with radiation. 3 years later, a lesion in the right arm treated with radiation, followed by radiation to 2 brain mets. And then finally, in April, another lesion in the lung treated with radiation. And then July, he remained off systemic therapy. So this is a period of time of 15 years where the patient's never seen a single drug and has no side effects almost from the radiation therapy and local therapies. And he has high quality of life, has done very well. And in this patient, it was kind of the right move to do this. Now, we don't know what the next scan will show. We never do. But this patient had a good run of 15 years with the brain met diagnosed at presentation with good outcomes. And this was just the scans in the beginning with the kidney and the brain. So what is oligometastatic? Now, what this entity is, as Dr. Sheth defined, is a patient where there's only a limited number of lesions. And that definition changes depending on what you're reading, either 3 or 5 lesions or less than that. We generally do 5 at MD Anderson. And we have looked into this and designed a trial, which we have completed with these good-looking gentlemen up top, some of you who you may recognize, in which we took patients with up to 5 sites of disease, either no prior systemic or systemic therapy for at least a month. We did biopsy, and then we did radiation to all sites of the disease. Now, at the time of imaging, if there was progression, and if that progression was limited to only 3 sites, then we went around the loop again and did more radiation, just like the patient I introduced in the beginning of this section. However, if there's more than 3 sites, then there's a discussion with a medical oncologist, such as Dr. Campbell or Dr. Tanier or Dr. Mazel, and then we decide that we probably need to start systemic therapy. And that's when you exit the trial. So these results were promising. We found that the progression-free survival, means time until the disease progresses, was about 2 years in these patients, and that most patients could be off systemic therapy for a long duration. Now, the problem is for a lot of these patients, like I tell, is that there's other microscopic sites. So more radiation usually needs to be done, and that's usually done at about a year from when the first site was treated. And we have patients, just like the first patient, where we've had 5 or 6 rounds of radiation at this point. And we just maintain them off systemic therapy for 6, 7, 8, 13 years sometimes. And they've done, and the general side effect profile is excellent. We have only 10% risk of significant side effects, all of which resolved a few months afterwards. The next entity I want to talk about is oligoprogressive cancer. So this is a 57-year-old gentleman who is on nivo-ipi. This is his history. He started back in 2012, where he had a left side nephrectomy. And then he started nivo-ipi because of a disease found in the lung. Now, flash forward a few years, and they're finding that all the lesions decreased in size, except for a few spots that were decided growing. We radiated those sites, kept them on the nivo part of the nivo-ipi, and the patient has done well for at least a year afterwards. And this is just the lesion in the lung, which is treated on the right with the radiation field. Now, what is oligoprogression? This is an entity defined in which patients who could have any number of mets at the time of presentation, at the time of drug therapy, are on an effective systemic therapy, usually 2 agents in kidney cancer. And on this therapy, all the lesions are doing well, except for a limited number, the oligoprogressive lesions, maybe 1 to 2 to 3, that are growing. And what we have seen in 2 trials is that by doing local therapy to these spots, we can prolong the time until the next drug is administered by about a year or so. So we can kind of extend the duration that the patient is on that drug. And these are 2 trials, one done in Canada and one done in Dallas, that show that. Okay, so palliation of metastatic sites. This is a 50-year-old woman currently with a painful right hip. Her history was she had a right side nephrectomy for kidney cancer back in 2016, had to have a lung nodule, started pazopanib, and then unfortunately 3 years later was found to have a painful right hip lesion. We radiated that. That's going to be shown up here with this lesion on the right hip, with usually a 5 to 10 day course, and the pain resolved afterwards. So there are many talks I could give about palliative radiation therapy because we've done a lot of research in this in kidney and other cancers. But a few questions and answers. So unlike the other entities that I described where we're trying to control the disease, the role of radiation here is to treat symptoms or potential symptoms that could arise. And so that is the definition of palliative radiation. It's really to reduce pain and suffering from the local effects of a tumor. What are some examples? So pain from a bone met, neurologic symptoms from a core being compressed or a nerve being compressed, bleeding, swelling causing symptoms, obstruction of airway bowels, or anything that's really what we think is threatening to do any of these symptoms. What is the major difference between palliative and definitive radiation? And it's usually the dose of radiation. Now, the days may be the same, but the dose we're going to give are going to be less generally for palliative radiation therapy. And then typically it takes 1 to 10 days to do the treatment. So, in summary, in terms of radiation folklore, the reason why we say radiation doesn't work for renal cell carcinoma is because of a number of benchtop data in the 1980s, where a single petri dish of kidney cancer, when exposed to a low dose of radiation, happened to have the most number of living cells afterwards. In addition, when we used old techniques of 2D radiation, back in the 1970s, we found that by radiating half or 2/3 of the abdomen after a nephrectomy led to a lot of problems, including deaths. And that kind of was the last time we did a randomized trial on radiation in this field. Radiation technique has really improved since these studies, and we are able to really target something with very small margins with really high doses and get around these problems. Now, in terms of primary kidney cancer, multiple trials, which it didn't show, but a large Australian trial across the country and New Zealand did show that there is good tumor control, about 100%, with SBRT, and that radiation therapy offers a non-invasive, a low morbidity alternative that we can control the primary kidney and other disease. In terms of oligometastatic disease, our recent phase 2 trial demonstrated the ability of radiation therapy to spur systemic therapy for select patients, not all, but select, and is potentially a good option. Now, pending validation in larger trials, this method of serial local therapy, whether it be radiation or ablation with Dr. Sheth or surgery with Dr. Mateen, represents an attractive option that we can defer drug therapy and their associated problems with quality of life and their costs, because these drugs can be quite extensive and require a lot of visits to come back and forth. In terms of oligoprogressive disease, radiation, including multiple trials, have demonstrated that we can radiate the progressing lesions in an event where there's a limited number and extend the time that a patient has on their current line drug therapy. Larger trials are needed, but this offers a non-invasive and really low toxicity way to maximize and squeeze every ounce that we can out of that drug therapy before we have to go on next line, which is usually a little bit less well tolerated and usually a little bit less effective. And finally, radiation has a long history of being used for palliation to metastatic sites. We can use this in many instances to palliate symptoms such as pain, bleeding, neurologic symptoms. So thank you for listening to me.